I think we will start. Yeah. Good. Yeah. Good afternoon, everyone. On behalf of PrepMedico and Nama Medicine, I welcome you all for this second session on the PLAB exam series. Unfortunately, I'm traveling, so today the session will be moderated by Nishita on behalf of me. So for the speakers for today, he's again a GMC registered doctor who has cleared his PLAB exams recently, and Dr. Nishita, who again have cleared the PLAB and the GMC registered doctor planning to move to UK very soon. So the theme for today is to discuss on the clinical scenarios for the PLAB 2 exam around surgery, ops and gynae. Taking the feedback from last time, what we are planning to do is Harish will start giving some basics about how the sessions would be, what is expected, what are the key areas where they need to concentrate. And obviously after that, he will be running sessions, and we want people to volunteer for doing the sessions. And at the end, he will give you a feedback of what is good, what is wrong. Again, please volunteer. Only when you volunteer, the entire session will be more productive and it will be useful. Again, you don't need to worry whether you have prepared or not. It is just a kind of a taster session for you all to know how these sessions are framed and what is expected in the exams. All right, so all the very best, and I will hand over to Nishita.
Okay. So let's start. Harish.
Yeah, let's start actually. Hello, everyone. My name is Harish. I'm recently cleared my PLAB 2. And I'm presently applied for some jobs, and I'm going to work as junior clinical fellow in general medicine. Today topics are we are going to discuss about surgery. Sorry.
Congratulations for the new job.
Thank you so much, Nishita. Okay, let's start. Today topics are we are going to discuss about surgery and OB-gynecology. So what are the main topics we're going to discuss for today are about history taking, and what are the presenting complaints in surgery, and what are the red flags that you need to rule out before we go further into the history taking part, and what are the differentials you could find in from the symptoms the patient had. And next is general and abdominal examination, what examination you do in surgery mainly, and basic investigations. These are all in surgery. We'll start with surgery, then we'll have a case discussion with Dr. Nishita. Then we further move to OBG and gynecology. Is that okay? Okay. Yeah. Let's start with taking. Okay, to begin with, first of all, when we enter the exam hall, actually, so first thing what you have to do is introduce yourself, like build the rapport with the patient. So as soon as you enter the room, you see the patient, you can you can say hello, greet them, hello, and wait for the reply, and try to introduce yourself. Tell, okay, my name is Dr. Harish. I am one of the junior clinical fellow, or FI2. You can tell what is your designation there. And once you're done with this, you can start asking patient details, because you need to confirm patient before you go further. So it's very important. Once you do this properly in the correct way, you're going to score here, because introducing yourself is the main IPS to be to be particular. So when you after introducing yourself, just ask about the patient name and confirm his details, date of birth, and his address. So once you confirm it, ask what is the purpose, like what was the reason for his visit to the hospital. So you'll have an idea about, okay, why the patient have come to the hospital. Okay, then the most important thing is smiling, actually, to be honest. Try to smile as much as possible, because it creates a positive impact while you're speaking to the patient. And, they're going to tell you more details. It's going to be useful when you speak to the patient. All right. Okay. Okay, how to introduce? There are like depends on the presentation. If the patient is presenting for the first time, you can ask what was the reason. You can ask like, how can I help you? Ask what is the reason for his visit to the hospital. But if at all the patient is coming for the second time, or if they follow patient, or he was admitted in the hospital, you can ask like, okay, you can start like, okay, I understand that you've been admitted for this and this, or I understand that you are come for the follow-up. So paraphrase it, okay, ask like why the patient has come, like what was the reason. Then if you go in this way, the patient will be very much happy that you're acknowledging that you know that what the patient has come for. So there'll be it creates a positive impact. That's what I meant. Okay, now, okay, once you do this, once you introduce yourself and basically ask patient, confirm patient details, now the next part comes. Okay, patient starts telling you about his concerns, like, or his symptoms to you. Okay, let's go this. Sorry. Okay. Let's go with what are the most presenting symptoms? Can you hear me? Is there any problem?
No, it's okay.
Okay, yeah, that's good. Okay, let's go. What are the common symptoms usually the patient presents within surgery? We'll start with surgery, then we'll go to OBG and gynec. Okay, what are the most common presenting symptoms in surgery? You can type, actually. Can you see the slides, right? What are the most common presenting symptoms that you see in surgery? Are the patient come with diarrhea, vomiting, abdominal distension, abdominal pain, change in bowel habit, bleeding per rectum. This is the one of the common symptoms, but there could be other symptoms that the patient may present with. So depending on the symptom and after taking some history, you can get an idea, okay, what kind of case it is or what kind of scenario it is. So always it's better that if you ask questions on this so that you'll have an idea, okay, what case I'm dealing with. So once you have a basic idea of what case it is, then you can move further and with your history taking or your examination and diagnosis. Okay, now let's go to the next slide. Okay, what the patient presents with pain. Okay, there is the various symptoms the patient may present with. It can be a pain, it can be in the abdominal distension, a swelling, a lumps, or bumps, urinary tract infection. It can be many symptoms. So when it comes to the pain, how you move forward? Okay, what are the questions you are going to ask about the particular symptom? So how are you going to ask? Like, is it because asking these questions will lead you to a diagnosis. Here, if you follow a particular pattern, you are going to ask all these questions so that you have a better understanding. Okay, this symptom or this thing is leading you to this the pathology. It could be due to the reason. To find out the pathology or to find out the diagnosis, we will be asking these questions. Okay, let's go with this. This is the just a mnemonic. Let's go with Socrates. Okay. S for side. Can ask the patient. This is for the pain, mainly for the pain. Okay, when the patient presents with pain, the first question you can ask is, okay, where is the pain exactly? You can ask him to locate the pain. With the tip of the finger, ask him to locate where is the pain exactly. So you know, okay, which part of the body or which part of the organ may have affected. You'll have an idea about it. So next we go to goal, that is onset. Was it sudden or gradual? So sudden onset tells us, okay, the cause may be acute, or the gradual one, maybe the symptoms have been chronic, or it has over the days it's getting worse. So that's why we ask these questions. Next is consistency, like what type of pain the patient is experiencing. Is it kind of pricking? Is it severe? Is it crushing? What a pain? What type of pain the patient is experiencing? Then next is associated symptoms. Okay, why is it important to ask about these symptoms? Is okay, the patient may present with a urinary tract infection. Okay, the patient may have a little irritation or pain while passing urine. So the infection may have ascended and have spread to the bladder, or to the ureters, or to the kidney. So the patient may present with loin pain this time. So these are the associated symptoms. So you can know, okay, from where the symptoms started and which way it's spreading or it's getting worse. So we ask these symptoms. So if you ask these kind of questions, you have a better understanding. Okay, what will be where we are going. Okay, next is time. Ask whether the patient is experiencing this symptom for the first time, or if the patient is experiencing at any different time. Is experiencing that in the morning or in the evening. Just I'll give you an example. Like in cholecystitis, the pain may increase after having food. So that's why we ask this question. Then next question E is about asking about any exacerbating or relieving factors. Anything that worsens the symptoms or anything that relieves the symptoms. So asking this thing will have better understanding what could have caused this patient this pain or what are the symptom he has. Then is scoring the pain. That it means severity. So you can always ask the patient to score his pain from 0 to 10. 0 being the lowest and 10 being the highest. So when you ask this question, the patient you'll have the grade. You can rate the severity. So when the pain is severe, definitely the patient won't be able to answer most of the questions. So you can consider giving some painkiller. You can ask the patient, do you need anything for the pain? So this actually it helps you in improving IPS. Once you have to build up on your IPS also, because your marking system will be scored on all these things. So it's better if you have an idea about this, and if you ask this question. And okay, now this is once you rate the severity. If at all the patient need any painkiller, you can give. Otherwise, you can ask the patient whether he is able to go forward with the questions or you need anything for the pain to subside. Yeah. Okay, now let's go to next slide. Okay, what are the questions you can ask for the symptoms? For any swelling or is there any distension? You can ask. You can use these mnemonic like food para. So F is for the frequency, whether the patient is experienced it for the first time. Okay, let me give you an example. Let's consider pancreatitis. Patient who had chronic alcohol history, the patient may have admitted for increase in pain from abdominal pain previously, maybe pancreatitis. So you can ask whether the patient was admitted before for the same symptom. So you'll have an idea, okay, this was due to this. You'll have a better idea about the thing. Then the next is onset. Was it sudden or is it gradual onset? Then the duration, when it started, how long it lasts, like about the duration of the pain, whether is it reducing, is it getting worse? D is for duration, and next is P progression, whether it's getting worse or getting better. So this is the way you can put it, you know, so that you won't forget. You'll be covering most of the questions. That's why I put this mnemonic so that you can follow this mnemonic. I know it's very difficult in the beginning to go in the order, but once you start practicing, you'll definitely improve. I mean, like it'll be there in the back of your mind. You can ask fluently, and you can continuously can ask all these questions. Don't need to worry about okay whether I will be spending more time on this. Don't worry about that. We'll speak about time management, what you can do to manage your time once you start taking your scenarios or taking history. Okay, A is for aggravating factor. Is there anything that aggravates the pain, symptoms? Or okay, let me give you an example. Okay, let's think about hernia, like umbilical hernia, ring venous hernia. The patient coughs, there is increase in size because there is increase in intra-abdominal pressure. So then you're relieving after some time it relieves. So you can by asking these questions, you'll understand what could have been the reason for these patient symptoms. And any associated symptoms, as I told you, like urinary tract infections, same, you'll understand what could be the pathology behind. Yes. Okay. So once the patient has told the symptoms, and what you wanna do mainly is you have to avoid, you have to rule out red flags. That's how you're going to ask the questions accordingly. So let's try to avoid, rule out all these risk factors. I mean, life-threatening conditions. Okay, let's consider a patient was admitted for surgery. So one patient was admitted and he is in post-op ward, and you are the FY2. You go there and you start assessing the patient. So what are the main things you can think of when you go to see a post-op patient? So ask his symptoms, whether you should. So usually, basically, we check for any dizziness and any bleeding. We change any swelling over the site of operation. Like you can check that. So when we have to check all these things because these are there be patients, post-op patients are mainly prone for this hemorrhage. So we need to rule out. We should have the basic, we should understand this. You should be able to rule out all life-threatening condition. Okay, let's go to other red flags. Can be dehydration. When the patient comes with some diarrhea, there with multiple episodes of diarrhea, the patient definitely lost lots of fluid. So definitely he'll be dehydrated. So we ask questions related to that, whether he is having any dizziness or is having any thirst. Thirsty is with thirsty is you want to drink more water. If you're drinking more water and the more dry mouth, and you have to rule out malignancy also. Malignancy is one of the main things in elderly, more elderly. We should think of malignancy when the patient has symptoms like weight loss, bleeding for rectum, fever, fatigue, malaise. I can give you a mnemonic to do what are the questions we can ask. When the patient, if you have it out, that it could be malignancy. Okay, let's consider. I'll give you a mnemonic called FLAWS. FLAWS, flaws. F is for fever. It asks whether the patient has any fever recently. Then L is for any lumps or bumps over the body. A is anemia. This is an internal bleeding, any shortness of breath, or when walking for short distance. Any W is for the weight loss, and S for nice weight. So you can ask these questions because it's easy to do load, malignancy. So weight loss is one of the main symptoms you should think about malignancy. So once you rule out red flags, most of the differentials would have caught by now. As of now, it's really difficult in the beginning to understand, okay, where is going. But over the practice, when you practice more, practice with different people, you'll have a better understanding on this. Okay, now in the beginning, when you start practicing for PLAB 2, you'll have a doubt like, okay, whether I'll be able to diagnose the case, what I'm going to do, like, but I'm not able to diagnose. What I suggest you is don't worry about, okay, I need to diagnose, I need to start treatment. First thing you have to do is whether you're asking in a correct way, whether you're following the correct pattern, whether you ask all the questions to the patient, what is very necessary, whether you are addressing patient concern. These are very important, to be honest. And I spoke about time management. Time management is very important. So what you can do to manage your time? Okay, what I suggest is let's divide your time into 3 plus 2 plus 3. Let's take this total 8 minutes. How are you going to do it is the first 3 minutes you can consider for taking history of the patient, taking history from the patient. And the second 2 minutes you can ask about his examination or about diagnosis. And the last 3 minutes you can keep it for the management or the treatment or other plans. Why do I give more time like for the treatment for management is it's not always just telling the patient, okay, we are going to treat you this, we are going to do give you this. There are so many doubts the patient would be having about his condition. Addressing those concerns is very important. So you may take much time in management sometimes because patient will have some doubts. Patient because explaining diagnosis will take some time. The patient has to understand what's going on with him, and he'll have some doubts about his diagnosis. So he'll definitely he ask some questions. So answering those questions is very important. Okay, now let's go to next slide. Okay, history taking. So what are the order of history taking? I put a mnemonic here. Just go with P method. So P is presenting complaint, like unpassed personal. So presenting complaints, let's go like this. See, by now you are already asked about this presenting symptom, presenting complaint or presenting symptom. You're asked about that. So once you're asked about that, you can go for any past medical history, whether the patient has any previous medical history in the past. That's very important because it will give you an idea of the presenting pathology could be related to this the past or the present. And what else you can ask after that past, and we can ask about personal history. Whether you can ask about do you smoke or do you consume alcohol, or do you take any other recreational drugs. Next goes with medications. You can ask the patient, is he taking any previous medications for anything like any diabetes or high blood pressure. So in the past, you can ask about this history also, like whether you have any previous history of diabetes. But all the patients say yes, and you can ask about any medications he's taking for this. If at all, if the patient doesn't have any past medical history, you should ask about any past surgical history also. It's also one of the important thing. And when you complete this present and medications, then you can go for A, that is allergies. Like you can ask about the patient is allergic to anything. Is he allergic to any antibiotic, or is he allergic to anything, any nuts? It will be useful to avoid any anaphylaxis allergic reaction for the patient in the hospital. And the next comes the family history. Family history is very important because in surgery, you can diagnose, you can suspect many malignancies based on family history. So ask about any previous family history of anything, any family history of any symptoms or any malignancy, so that you can think it helps you in diagnosis. Sometimes it will actually take you towards the diagnosis and management. And next is asking about travel history. Ask about travel history to know about whether the patient have traveled recently to any place. Like, okay, if the patient had eaten any food outside, which is infected, like hepatitis could be caused due to infected food. So asking these questions is very important. As travel history. Then you can ask about occupation. What kind of occupation is he doing now? Because some workers who work in these chemical factories where benzene content is high, they may have carcinoma of the scrotum. So ask the occupation is important, what kind of work he does, and whether he's presently working or not. And asking sexual history is one of the important is important because you need to rule out any sexually transmitted diseases in this patient. And ask about social history. What is he doing? Like where is who he stays with. So why social history is important is you can actually rule out is the why the patient has come to the hospital. Maybe he doesn't have any support. So social history is one of the one is also important when taking history from the patient. Okay, after asking all this PMFTOSA, you definitely it's not always that you would have asked all the questions from the patient. So it's better to ask the A, that is anything else that you would like to tell us. This is important because sometimes we may have forgotten something or we have not asked something that is very important for our for diagnosing the patient or helping the patient. So asking this question may provide an opportunity for the patient to explain some new symptoms that we would have not covered in our history taking. So this is also very important to ask this question at the end of your history taking. If you cleared all this PMFTOSA, so you can asking this question is very important. Yeah, let's go to the next question. Okay, differentials. So whenever you get a symptom, think about the differentials. Okay, how I'm going to explain this to you is once you enter the station, once you get to the station, like when you get time to read about the case, you can read about the case. Like you'll have a small understanding about what the symptom is, and you can think about some differentials, and you can think about some questions what can be asked related to the symptom. So when you before entering the station, you'll get nearly 1.5 minute time. So what I suggest you is utilize this 1.5 minute to the best. You can actually frame some questions what need to be asked in this scenario. Okay, let's consider. Yeah, let's take this diarrhea patient. If the outside was mentioned, if it is mentioned like the patient have come with diarrhea. Okay, think about what could be the possible differential for this patient. You know, what are the conditions that lead to diarrhea? Gastroenteritis, sometimes food poisoning, but not like inflammatory irritable bowel syndrome, celiac disease, chronic cancer, colon cancer. And depending on the symptoms, that you can try to have have in the mind that okay, this could be due to this reason. So if you have some questions to ask to him to rule out some other diagnosis, it will be useful to save some time for you. So here I mentioned okay, what are the differentials you can think of in vomiting, like food poisoning, obstruction, intestinal obstruction, any medication, side effect of medications may lead to vomiting, and hepatitis can lead to vomiting. Okay, what is abdominal distension? What are the things, what are the differentials you could think of when the patient comes with abdominal distension? I can think of abdominal obstruction, any tumors that is blocking the patient's bowel movement, or any liver diseases and any recent surgery. Recent surgery can be due to leakage of the anastomosis part, or it can be due to the bleeding. And abdominal can also be caused due to paralytic illness. Okay, next we go. Okay, before going to examination, there's one more thing that I'd like to explain to you is This is the time where you would like to ask the question about, ask the patient about what they think about the symptom. I say I'll give you a mnemonic called ICE, ICE. Okay, let's see. I is for the ideas. You can ask the patient, do you have any idea what could be the cause of your symptom? And do you have any, what do you think is the cause for a symptom? You can ask this question to the patient. Asking this question is very important because that sometimes you'll get a diagnosis from this. Because the patient, maybe you not ask some question, maybe the patient will tell by himself, okay, I think I have this symptom because of this. And asking these questions it also helps in improving your IPS. Improving the IPS is very important. You have to asking these questions helps you. And the next is C, risk concern. What is it? What the patient is worried about? You can ask the patient, are you concerned about anything? What are you really worried about at this point of time? Because a patient, before coming to the hospital, now discuss with the friends or colleagues, family, and they are told some diagnosis to them, so they'll be concerned about particular infection or particular diagnosis. So ask them what are they really worried about. So it's sometimes the patient or elderly patient is worried about malignancy, so they'll be worried about the thing. So once they tell about, okay, they're worried about this thing, think, explore why do they think could be the reason, could be why do they think it could be a specific diagnosis. Ask them why do they think. So when you ask this thing, you're going to explore the reasons for him to think in this way. Once and then validate. When he says, okay, this is the reason I say this, then you say, okay, yeah, I understand that it could be one of the reasons for symptoms. This is validating the patient's concern. And next is empathize. Okay, empathize is being polite and telling the patient, I'm really sorry that you're going through this. Is there anything that I can do to help you? So asking eyes is very important because it'll help you in addressing patient concerns at this point of time, and also it helps you in diagnosing the patient's pathology. Okay. Now let's go to after this we can next after eyes we can go to examination part. But before going to examination, what you can ask is explain the patient about what you're going to do next. I'll share the next slide. Okay, taking consent. Before we jump into examination, taking patient consent is very important. Tell the patient, take permission. I would like to do this examination. Okay, is it okay with you? And tell him why you are doing this examination. Why is it necessary? Was it very necessary to do this examination? So when you explain the patient why you are doing this examination, they will be very much happy and they'll give consent, give permission for the examination. So doing this actually adds up to your IPS because this is very taking consent is very much necessary while practicing in UK. So once you take permission or once you ask permission, explain patient and then offer patient privacy and tell them that you're going to offer chaperone too. So once and allow the patient, provide some privacy to the patient to change. Tell them what you need to see. Explain to them. Okay. So once you ask the patient to expose adequately, tell them. Then you can explain what examination you're doing. Okay. Let's see what we can explain to the patient. Okay. In abdominal examination, tell the patient I'm going to look to the abdomen. Okay. Look into abdomen. Look from the foot end of the patient. We are doing this to make sure that all quadrants are moving equally with respiration on both sides. In some cases, like if there's any tumor or if there's any swelling, the movement won't be equal. If there's any the movement won't be equal. So then what else you can look is look for any distension, any abdominal distension, any redness over the abdomen, any swelling, any sinuses, any dilated veins. See any abnormal findings on the abdomen. Then ask the patient to cough. We're doing this to look for any umbilical inguinal hernia. So when ask the patient to cough, there's a chance that the hernia bulges up. Okay, this is how the inspection would start. The examination will start. After this, we can go for the palpation. That is, in palpation, what are the things you're going to check in palpation? Check for patient's temperature. How do you check for temperature? Use back of your hand and compare with the thigh in both sides. So you'll have an understanding, okay, whether the particular area is hot or cold. You'll have an idea about that. Then palpation, it can be superficial and can be deep palpation. Okay, let's go with superficial palpation. That is, check for any guarding, any rigidity, and any tenderness. So why do you check for guarding rigidity? What you are going to diagnose if this is any peritonitis, there will be guarding and rigidity, peritonitis. Next is deep palpation. Deep palpation, we are doing this for any abdominal muscles, any a bit deep abdominal organs like any liver, spleen, and we also palpate for the kidneys. And while doing deep palpation, be gentle. Sometimes the patient may have maybe a painful in particular quadrant. So what you can do is ask the patient where the pain is and avoid the particular quadrant. Examine all other quadrant. At the end, you can come to the quadrant which is painful, and we can examine accordingly. So in deep palpation, what are the things you can you like to examine? Main abdominal organs are, you can check for liver, spleen, kidneys, abdominal aorta, intestine. So let's go with gallbladder. Okay, Murphy's sign. You all know what Murphy's sign is. It is sign which is elicited when there is cholecystitis, there's inflammation of the gallbladder. So how we are going to perform this? I know you already have dealt with this. So this is not different. It's actually same way that you thought in your MBBS exams. I'll show you a picture of this. Okay, this thing. So try to keep your fingers parallel to the postal margin and ask the patient to breathe. So when you are breathing, when the patient is taking inspiration, try to press. Then, if at all your fingers touches the inflamed gallbladder, due to the pain, the patient stops breathing in mid-inspiration. So this is this is called Murphy's sign. So it's positive in acute cholecystitis. This is how you are going to do for Murphy's sign. Okay. Next is palpation for the liver. So for palpation for the liver, from where you are going to start? So you are going to start from the.
Guys, Harish, I have a doubt. Can I ask?
Yeah, please.
Yeah, for abdomen, we will go generally with inspection, then auscultation, then percussion palpation, right? Generally. Yeah.
Yeah, it's nothing wrong if you are not going that way, but this is the way I followed in my exams, so that's why you can follow that way, no problem.
Because actually, we in BATES, they have mentioned that for the abdomen, remaining for everything, IPA, we can go for inspection, palpation, and auscultation. For abdomen, inspection, auscultation. Am I correct? Is it okay? Just correct me if I'm wrong.
Okay, definitely. Even I'm really not sure about it. Definitely, I'll see about it and I'll get back to you. Thank you for giving me a.
Yeah, so if I say anything wrong, it's okay.
No, definitely. I think maybe I should update. Yeah, thank you so much.
No, what's the doubt? Can he repeat once?
Actually, for abdomen, generally we'll go with inspection, then auscultation, then palpation, then percussion. Actually, in our med school, they have we have ASM in BATES. In BATES also they have like that. For abdomen, generally we'll go
Okay, but in UK and the way we have prepared and we have done the PLAB 2, it's always like inspection, palpitation, then auscultation, and then in the end we have before auscultation we have percussion, then
Yeah.
in the end we have auscultation.
Yeah, actually, she also mentioned the same query as we disturb the bowel sound. So I think you just correct us. So we are in
So what
confusion.
bowel sounds like? How will it affect?
Okay.
While doing percussion,
Mm-hmm.
yeah, it may be
It
doing
may want.
yeah.
So Sundar, Soumya, we can have a discussion. It's okay.
Yeah, yeah.
Yeah, it's
Don't
okay,
worry.
Harish. I'm so sorry for this.
No. Please,
Oh.
you can always ask me any doubts.
Yeah, definitely. And I really want it to be a discussion so we all can talk. It's okay. No, it's that's what I'm saying. It's not disturbing. Please.
Actually,
Want it to be interactive with us.
can I take 1 minute? Gaurish, please turn on your cameras. Everyone, Sundar, please turn on your cameras. So it will be more interactive. I'm outside here in Philippines. It's earthquake, so I couldn't turn on the cameras. So can you please turn on the cameras, guys? Gaurish.
Sure, definitely.
Am I visible to you?
Yeah, you are audible. So it is something like showing respect. No, we will follow in our medicine. So turn on the cameras. Yeah.
Am I visible to you?
No, you are not visible. Okay,
Oh.
thank you so much. Sorry for this. You can take the platform now. So sorry.
No problem. Yeah.
It's just to keep the session interactive. That's all.
Yeah, true. No, it could be actually. We'll also check on that. See, now we can have a clarity. We'll check and we'll put it in the Telegram group so that you'll have a better understanding, which is the correct way of examination. Yeah. Okay, cool. Fine. Okay. This is for the. Okay. So when you're palpating for the liver, start from the right lower quadrant. Because when you start, if at all there is any enlargement of the liver, so it'd be easy for you to find out. So when you start, ask the patient to breathe. So when the patient is inspiration, just keep your fingers on the tummy. So when the patient is expiring, just try to press so that you can feel the lower border of the liver. So this thing actually after some time, definitely we will try to conduct an offline class, or we will create some videos and virtual videos so that you'll have a better understanding. It's just a pictures. I couldn't put any video in here, but we'll definitely try what we can do better in the future, right? Okay, for when examination of the liver, let's know how the examination. How do you examine for the spleen? It's actually same. We start in the right lower quadrant, then move towards the left coastal margin to see if there's any enlargement of the spleen. So same, we ask the patient to breathe, and when the patient is expiring, just try to press, and you can feel the spleen in the region actually. Okay. Okay, what other abdominal palpations we do is we can check for abdominal aortic aneurysm. So you can see the patient, the exam is trying to palpate, is moving from outside towards inner side. You can see the bonding movement of the artery. So once you feel that you can suspect that could be abdominal aortic aneurysm. And what you can do is you can confirm this with ultrasound scan. It's always clinical examination, then you confirm with the other scans. Okay, these are the three things you palpate. And what is next? You can go for percussion now. So you can percuss for the liver and percuss for the spleen to check for the liver span and the spleen span. Liver span, usually liver is enlarged in hepatitis and in hepatitis. So you can start percussing from the chest and go down, check for the dullness, and see how far the liver is there. You will be able to check for the dullness, and you can measure that, and you can see the like how much the enlargement of liver is seen in this patient. Same for the percussion for the spleen. Now the other percussion we do importantly is for the ascites. So for ascites, first we start from the epigastric region and keeping your finger horizontally from the epigastrium, go down and check for the dullness. So sometimes the abdominal restriction could be enlargement of the bladder. So we do this test. The second percussion goes from the umbilicals, goes towards sideways when it's in the longitudinal direction. So once the percus go towards one side, and if you feel any dullness, ask the patient to turn the opposite direction and wait for 30 seconds to 1 minute. So once the patient and the fluid move, then again start percussing towards umbilicus and see whether there is any fluid in the abdomen. So that's how you're going to diagnose, ascites in some patients. Okay, this for the percussion. Next is auscultation. So auscultation, what are you going to auscultate for? You need to auscultate for bowel sounds. You have to keep ideally for 1 minute, because the number of bowel sounds will be like 3 to 4 for a minute. So just listen. You can place the stent below the umbilicus and wait for check for the bowel sounds. It is usually increased in any intestinal obstruction. Next, what you're going to auscultate is for aortic and renal fluid. How you're going to do is where you actually keep the stent is above umbilicus, and to each side respectively, you can feel there's any aortic or renal fluid. Okay, you usually when performing abdominal examination, there'll be you can mention that it is ideal to do rectal examination in this patient depending on the symptoms. So you have to mention this, and finally you can finish your examination by examining the lymph node, like inguinal lymph nodes, any swollen lymph nodes. So swollen lymph nodes usually indicate if there's any infection or there's any malignance, metastasis. So once you finish your examination, thank the patient. Thanking the patient is very important. Thank him for allowing for the examination, and provide privacy for the patient, and ask him to dress up. So once the patient is dressed up and is ready, and make him sit, and you can start explaining about your examination findings to the patient. So start with the inspection. So what are the findings you had seen in inspection? Explain to the patient what are the things you found in inspection. And next you come to explain about the palpation, what are the findings you found. Then percussion. Then comes the auscultation part. So we can explain this to the patient. So after explaining about examination findings, there are a few tests you can do in surgery, depending on the symptoms and depending on your you cannot do all the tests for every symptoms, right? So depending on what you think could be this diagnosis, you can order but what I suggest is there is some basic investigation that you can tell to any patient. Those basic investigation is capillary blood sugar. Then you can go with urine dipstick, UPT for urine pregnancy test for females. Then you can also tell ECG. So you can perform these tests for any patient, so that you'll these are basic tests. So if you mention this, it's very good. It'll actually add up to your overall performance. So next to what investigations you can ask for the patient depends like FBC. If you suspect the infection, FBC you can order. Check for any rise in red blood cells. Then check for inflammatory markers, CRP. ESR, check for inflammatory markers. Then if you like to order some liver function test, you can ask for that renal function test. But what matters here is mention every test that you'd like to do to the patient. Don't be like, okay, I assume no, like whatever you feel like doing, just mention that. Okay, I'd like to have this test for my patient. I'd like to have this thing for my patient. So once you say this, if at all there is some examination or blood results, they'll give it to you. So unless you mention this, they're not going to give you results. You'll never get the reports if at all there are any reports available to you. So mention these tests. So you can also mention about ultrasound scan or CT scan if at all is necessary for the patient. So once you're done with your scans, if at all get some result, now comes the last part, that is diagnosis and the management of the patient. Okay, let's go with the diagnosis. So explain the diagnosis to the patient is very important. How are you going to explain to the patient? It should not be like, okay, you have this. Uh, be like try to speak to the patient and try to show empathy while explaining about the diagnosis. Okay. So how are you going to, I'll tell you how you explain to the patient. Okay, from what you told me, so from your information, from your history, and from what I can see from investigations or from the examination part, I suspect you could have this. Okay, you could have some appendicitis. What are the symptoms and what are the diagnosis you feel? You can say. And when it comes, okay, telling this symptom, this diagnosis is fine, but when it comes to carcinoma, any other serious condition, you have to use the sign language, like tell them, unfortunately, I'm really sorry to hear this. I'm very sorry to say this. I suspect you could have a carcinoma of or malignancy of. So the patient, obviously, when you say this, the patient will be having so many questions. That's the reason I divided history taking part into 3 plus 2 plus 3, so that if at all some questions comes up here, you'd be able to take some time and explain to the patient. So we'll explain to the patient, if at all if you are referring in a cancer pathway, you should tell the patient, because the patient will be worried that once you suspect, the patient will be in a situation thinking that he may have, that he have cancer. So you have to explain them, this is just you're just suspecting it, we are just doing this to prevent, just to rule out malignancy. And some many patients, and you can also say that sometimes when you go through this test, even though it will be normal sometimes, so you can explain this to the patient so that they'll be relaxed. So once you are once you know, if there's any facility available at the center, you can do the test there. And with no like for all it's periphery center, or if it's in GP, or there's no further treatment or further investigations not available there, then it's better to refer them to IS center, or just refer them to specialist. You can do accordingly. So it depends on what diagnosis you are going to give to the patient. And if at all, if you can treat the patient in the place where you are, like you can ask the patient, tell the patient, give them some management, ask for the follow-up, and you can give him some lifestyle advice. If at all the patient is smoking, and if at all that you're suspecting any cancer, you can ask the patient to reduce the amount of smoking. And you can ask the patient to reduce the amount of alcohol consumption if at all the patient is there, and advise him on their diet. If at all you feel the patient is weight is more than the normal, for BMI is more, then you can ask him to refer him to the dietitian. So you can use all these things so that you're like the management part will be good. Don't don't always tell only single management and just stop there. No, you can always explain, and you can always tell about lifestyle advice. There are many things, regular exercise. I can provide a leaflet on the patient condition so that you'll have a better understanding. And you can also safeguard, you can also ask the patient, if at all the symptoms get worse, if at all the patient is getting worse, you can always come back to the hospital. So you can say all these things so that it will be reassuring to the patient. Yes. Okay, these are the surgery things. These are the issue taking part, and how the management. I would like to answer any questions if you guys have on the surgery part. I'll try to answer you guys. And if anyone has any questions, please. Hello. Any question, guys? Sorry? I couldn't hear you. Sorry.
Someone has some questions in the chat box. Can I read?
Okay.
Would you suggest?
Please read the question, please.
Would you suggest reading Macleodus or Hutchinson clinical examination book for reading, history taking, and examination as I feel I'm very weak in both, or would you like this be covered by academics? Arjun
Yeah,
Garg.
Arjun?
Arjun Garg. The
Okay,
question.
Arjun. Hello, Arjun. You have asked a very good question, actually. Even I cleared my PLAB recently. I know how it feels. Even I thought, okay, I'm not good at taking history and examination part. But what I suggest is, once you start practicing, just whatever I explained to you, history taking part, just first start practicing that. They start taking history in this way. After in the beginning, it'll be difficult. You won't be able to cover, but after 10 history taking, you'll have a better understanding. I know you like to read McLeod's or what other book you wanna read, but what I suggest is the book is not very small. I have seen the book. The book is very huge. uh, so what I suggest is practice. Instead of first practice, if at all you're not getting better, you can always ask us, like, how do you improve your history taking or examination. We'll definitely help you know matter. We'll definitely help you with that. We have been in the situation, and the examination part now you may feel difficult, but when you see it in offline, or when you do it yourself, you're going to gain confidence. First thing is, gaining confidence is important. For that, start practicing as much as possible to you. And you can always put your doubts or your queries in the Telegram group, and we'll definitely try to help you with that. So if you have any further doubts, definitely we'll help you with that. So as of now, try to practice. If at all you're not able to not able to take good history, or you're not good at taking the examination part, then we'll suggest you some books. Is it okay? Any other doubts, please?
Sorry, doctor.
Yes.
Yeah, just wondering if, let's say, an abdominal case comes. So during examination, am I expected to complete the entire abdominal examination, or can I skip some part? Let's say I'm not suspecting any liver pathology. Can I skip the percussions of the liver?
Okay. I get your answer. You are asking the question like, okay, if at all I don't suspect anything, like if at all I don't suspect ascites in my patient, ascites in my patient, can I not? If you don't want to do percussion, that's what you mean, right?
Yeah, if let's say I'm not suspecting a certain pathology in certain organ, can I skip that part?
Okay. What I say is, they're not asking you to diagnose everything and you have to be very perfect. They're asking whether do you know to examine whether okay, how to explain. Okay, I'll say this. If you follow the examination, that is inspection, palpation, percussion, auscultation, if you're doing in this order, what they're expecting is whether you know how to examine a patient in a correct way, whether you are trying to cover all the parts which that could have lead to the pathology. So if at all you are thinking that, okay, I don't want to do this because I'm not suspecting this, that's not right. It's better if you do all the examination.
Okay, got it.
Or maybe if you don't have time, at least vocalize. Don't do it, but vocalize. Ideally, I'll be doing this, but do the thing which is required. Okay.
Okay, got it. Thank you so much.
No, is your doubt cleared? I still have a doubt. You can please ask.
Yeah, I understand. Thank you.
No problem. Any other doubt you guys have?
Okay, then let's start with the session.
Yeah. Before starting a session, we have Dr. Nishita with us.
Not me. Let them have a practice once, then
Okay.
we'll do. Okay,
No
guys,
problem.
please practice, because this is the best chance you have to practice, and like we are the better judges than your friends. So please raise your hands and be there. Okay. So who's going to come up? Arjun? He's not there only now. Anyone else? Guys, speak up because like this is important for you. We have given our exams. Just listening won't help. To be honest, you have to be there.
Guys, I have been in your position. I never asked a single question while I was attending my online class. Thinking, oh, I'll ask some dumb question. Don't worry. I'm telling you, if we are here. We have been in your position. You can ask us any question. We are not going to judge you on that. We are really going to help you. You can always freely ask questions to us.
Mm. Come on.
Please type the questions if you don't want to ask it.
Wait, I'll ask someone.
Don't scare.
So no one wants to do? At least say no.
Hi, actually, I joined late. I mean, I can give a try though, but I'm not
Very
sure
good.
about
Proud
the
of you.
surgery format yet.
No problem.
It's
No
okay.
problem. Yeah.
Yeah, so Dr. Harish, please give us the case. What's your name?
I'm Priestlin.
Ah, nice to meet you. So Presley will do it, okay?
Okay, yeah, sure.
Okay. Okay. Sorry, I didn't get your name, please.
Priestlin.
Preslin. Okay, Preslin. Hello, Preslin.
Hi.
Okay. Let's a 24-year-old male
Okay.
had come with a history of vomiting
Okay.
and diarrhea.
Okay.
Okay, I would like to. Okay, I'll just take it this thing. I'll have a question here, so that you'll have a better. Okay, so the question is not here. Okay, fine. I'll explain you. No problem. 24-year-old male who came with history of vomiting and diarrhea, and he also had history of weight loss. Yeah, you are in FY2 in acute medical unit.
Okay.
Okay. Please address patient concern.
Okay.
That's it. Simple.
All right.
Okay.
Good morning. I'm Dr. Priestlin. I'll be the treating doctor for today. So before
Wait a
starting,
second. I'll start the timer for you. Just a second.
yeah, sure.
Okay.
Just let me know whenever you're ready.
Yeah.
Ready?
Okay. Yeah, sure.
Good luck. Start.
Good evening. I'm Dr. Priestlin, and I'll be the treating doctor for today. So before going any further, can I confirm your name and your date of birth, please?
Hello, doctor. My name is Harish. I am 24-year-old and my date of birth is 17/7/1996.
All right. So what has brought you today, Harish?
Doctor, I have been having this vomiting, doctor, from last 1 week, and I was loose stools.
Okay. So can I know since when all this symptoms started?
It's been a week, doctor.
Okay. So can you tell me more about the vomiting that you have, like the number of times that you have in a day?
I like more than vomiting. I have more diarrhea, doctor. Vomiting once or twice, but diarrhea I'll have it like 3 or 4 times a day.
Okay. So all of this has suddenly started just a week before, right?
Yes, doctor. It's been one or 2 weeks. Yeah, not more.
Okay. I'm so sorry to hear about that, but can I know a little more detail about your work, if that's okay with you?
Sure, doctor. I work as a bank employee.
And can you tell me about your usual diet habits, like what do you eat?
I eat a lot of wheat and barley, doctor. And like recently, I started eating wheat and barley.
All right, okay. So, um, can you tell me if there's any other concern apart from vomiting and diarrhea?
Sometimes have abdominal pain, doctor.
Okay, all right. So, is that pain uh, more during more when you're consuming food, or is there a particular time when you get that pain?
Yes, doctor. After consuming food, after some time, I feel more pain, abdominal pain. Yeah.
Okay, all right. Can you tell me where do you feel the pain exactly?
It's just here, doctor. Here in the epigastric region. Yeah.
All right. Okay. Yes. Okay. Okay. Thank you so much for answering all the questions. So, did you have any fever
No,
for the
doctor.
past
No
1 week?
fever.
All right. So, did you face with any weight loss? Do you feel like you've lost weight over the past few months?
Yes, doctor. Now I'm noticing. I think I lost some weight. My clothes are very loose now.
Mm-hmm. So, can I know a little about your past medical history? Are you hypertensive, or are you on any meds? By
No, doctor. I'm not hypertensive. Neither am diabetic. I am not on many medications.
All right. Thank you. Um, so okay, we'll move on with examination. Can I examine your abdomen a little bit, if that's okay?
Why you wanna examine my abdomen, doctor?
Because you told that you had pain over the epigastric region. I'll check if it's during due to muscular, or is it any other pathology that might help me with coming up with a diagnosis. So if that's okay with you,
Okay, doctor. It's only abdomen, right?
yeah, I'll just be a
No problem, doctor. Please move on.
okay. So
No abdominal findings in the abdomen. Yeah. Inspection,
all
palpation, auscultation, percussion is normal.
okay. So Mr. Hari, so we'll as as I've collected your history, and after done with your examination, I feel like it might be due to your dietary history. As you've told, you've consumed a lot of meat lately. I don't think this is a very serious condition or a very big matter of concern.
What should I do, doctor, now?
Okay, so um, right, I'll okay. I actually don't know how to take it further.
Hey, no problem, no problem. You did really well, really well. It's just starting. It's good. You did good. You're done?
5 minutes.
Oh, that's still 5 minutes.
No,
What?
5 minutes done. Yeah, you had 3 minutes
I
remaining.
understand.
It's okay.
Are you done, Presley?
Yeah.
Yeah, okay, that's great. That's great. You really tried. Good, really good. You did really good.
Thank you.
Okay. Do you like to get feedback? Is it okay?
Sure. Yeah, please.
Yeah, please. No problem, no problem. Yeah, that's really good that you introduce yourself. First you came, you introduce yourself and ask me and they confirm my address. That's good.
Mm-hmm.
Then you asked me about my presenting complaint, why I am visiting hospital. I told stomach pain, and you asked me about okay when it started, where it started. You got pain. That's good. That's good. Then you asked about some examination you did. That's great. And okay, the management part is okay. We'll keep it there. No problem with that. Okay. Now, like, what thing is, when you start, I told you that I had a diarrhea, right?
Yeah.
So when you ask about diarrhea, what are all things you like to ask? You know, see whether okay, I asked like I told 3 to 4 times. You can ask whether there is any blood discharge, any
Yeah,
mucus
yeah,
discharge.
right. Mm-mm.
So yeah, depending on what symptoms I tell, related to the symptoms. See, I asked about vomiting. What was the vomit was like? Is it blood and is it normal?
Yeah. Mm-mm.
What are the content?
Yeah.
Yeah, like ask about it. And what you didn't do is you should have followed the P method. So you asked about my, about my medical history. That's good. But if you follow P method, so you'll cover most of the things.
All right. Okay.
Got it?
Yeah. Yeah. Got
That's
it. Got it. Yeah.
That's good. That's good. So next time, follow P methosa.
Okay. All
And
right.
one more is highs.
Any other concern and
Any other concern? So that I'd have told you some extra points. Like I'd have
Right.
helped you out in the diagnosis. To be honest,
Yeah. Right.
but it,
And one more thing, don't use the word epigastrium. Instead of that, use tummy. Because the patient will be like, what is epigastrium?
Yeah.
Yes.
Yeah. Okay.
Use layman language, okay?
All right. Yeah. Sure.
Yeah.
Okay,
Thank you so much, Betsy, for asking all these questions. And whenever if you don't know the diagnosis, if you don't know the management, you can always ask. I suspect this thing, but I would like to ask my senior. I'd like to speak to
All right.
Hmm.
Yeah.
Cool.
Yeah. Sure. Cool.
Wonderful, wonderful. Thank you so much for participating, for volunteering.
So this must be celiac, right?
Yeah,
Okay.
that's great. You know the diagnosis. It's just you have to ask in the correct questions.
Okay.
You'll
Right.
come to the diagnosis.
All right.
Okay, so what other tests will you ask for the celiac disease? Investigations?
The celiac, I'll be checking the levels of vitamins, minerals, iron profile and all. Because
Okay, good. And profile. That's good. Yeah. Due to they'll be bleeding inside. Yeah, that's good.
and I think DEXA also.
Specific test.
Sorry.
One test, specific test is there.
Anyone else? Like
So
anyone can
transglutaminase.
Tissue,
yeah.
tissue transfer.
Tissue transglutaminase. Yeah.
That's correct.
All right. Thank you so much.
Yeah, thank you.
Okay.
For participating. Yeah. Okay. Okay. Let's move to the next thing. Okay. A few people asked about last time we got a feedback that we'd like to do a case. Like whether if we do a case, how it's going to do. Nishita, are you okay to do it now?
Okay.
Yeah, that's great. Hi guys, this is Dr. Nishita. We did PLAB together. She is very good at her IPS. I think you should definitely practice with her when you get some time. Okay, let's go to the next question. I'll ask you. Okay, Dr. Nishita will be the doctor and I'll be the patient.
Okay, I'll just open my video.
Let me know when you're ready.
Yeah, sure, go ahead. Tell me the case.
Okay, I'll give you the case. 1 sec. It's loading. Okay. You are an FY2 doctor in GP surgery. Hello.
Okay.
Okay. I am the patient. My name is James Parkinson, age 55-year-old, and I have an appointment to see you.
Mm-hmm.
Talk to me. Talk to the patient and address his concerns.
Okay. So basically, you just want the patient wants a PSA to be done.
Yeah. The patient has just yeah. That's what.
Okay.
Okay. Yeah. Let's start.
Anything? That's the info I have, right?
Yeah, that's the intro I have. Then remaining questions I'll start
Okay.
asking. Yeah.
Okay. Okay. You'll start the timer or should I?
Yeah. You start the time. That'll be better.
Okay, I'll start. Hello.
Hello, doctor.
I'm Dr. Gandhi, one of the doctors in this hospital. Before proceeding, could you please confirm your full name and your date of birth, please?
My name is James Parkinson. I'm 55 years old. My date of birth
Okay.
is 12/9 and 1960.
Okay. And nice to meet you, Mr. James. Is it okay if I call you Mr. James?
Yes, doctor, no problem.
Okay. So, James, what brought you here today?
Doctor, can I get my PSA done, please?
Oh, I understand that you're very worried right now, but before that, can you tell me what do you know about PSA?
Doctor, it's called, it's related to some prostate, right?
Exactly.
Yeah.
Okay. So,
Uh,
why do you want your PSA to be done? Is there any particular reason?
Doctor, I don't know. My friend, I used to play golf with my friend. He was well, actually. Suddenly, he was diagnosed with prostate cancer because his PSA was high or something. So I'm worried that maybe I have cancer.
Oh, I'm really sorry to hear about your friend, and I can understand that you're very concerned right now, and it's definitely a valid concern. I'll try my best to help you out, okay?
Yes, doctor. Can I get it done?
We need to assess you before getting giving you any investigations or any tests to be done. So for that examination and for knowing you, I need to ask you a few questions. Are you okay with that?
Yes, doctor. No problem.
Okay. So before proceeding, could you tell me if you are having any kind of pain in your body, maybe a back pain?
Not specifically, doctor. No bad pain. Sometimes I get my knee
Okay.
pain, but not any body pains as such.
Okay. As you mentioned, you play golf. By any chance, while playing golf, do you have any pain?
No, doctor. Not I remember.
Okay. And by any chance, have you lost any weight recently?
I didn't check my weight, but I don't think so.
Okay. Maybe any clothes getting loose?
No, doctor.
Okay. And by any chance, did you have any difficulty in urination?
Urination. I pass more urine. Maybe that due to my diabetes, but nothing. No other symptoms as such.
Okay, so you have diabetes, right?
Yes.
Except for the diabetes, do you have any other past medical history?
No, doctor.
Okay. And what are you taking for diabetes?
I take metformin.
Okay. And except for the metformin, are you taking any other medicines?
No, doctor. I'm not taking any other medications.
Okay. So, is there anything else that's concerning you except for your friend who has been diagnosed with something like that?
I'm worried, doctor. He was well, he was fit, he was having ways to play golf, he had no symptoms. And suddenly I came to know that the cancer spread in his body and now is in critical condition.
I really understand life can be cruel at times. Okay. Anything else except for that which you're worried about?
Not really, doctor. I'm just want
Okay.
to make sure that I don't have anything like that. So I'd like to get this tested, doctor. Can you explain more about this PSA to me, please?
Yes, sure. So basically what PSA is a test in which we check for a specific antigen that is known as prostate specific antigen.
Okay.
Okay. So on the basis of that, we decide whether a person is having a condition known as BPH, that is benign prostate hypertrophy, or the patient is having cancer. Okay.
Okay.
So it's a screening test. You can say that this PSA testing is not a diagnostic test. Okay, and this is a test which can be false at many points of times. If you have if you have some UTI, then also PSA will be increased. If you have any infections in your body, if you have recently done any sexual activity, then also there are chances the PSA can be increased. Okay.
Oh, okay. I know this, doctor. I
Yeah.
thought it
So
was
there are many reasons.
okay.
Okay.
Can I have it done, doctor?
You can have it done, but right now I don't think it is needed in your case because I have asked you a few questions, and the good news is there's nothing which is not wrong in you. Okay, everything is quite normal at the moment.
Okay, doctor.
Okay, But yeah, if you are really worried and if for your satisfaction, I will get it done, because actually PSA is something which we prefer people doing who are over 50 years of age.
Yeah, I'm over 50 years of age.
That's why I will definitely send the investigations for you, so that you can get this PSA thing get tested. Is that fine?
That'd be great, doctor. Can you tell me what to do if at all my PSA comes out positive?
Okay, so if your PSA comes out positive, then we have certain things which can be done. Firstly, we will check the levels. If the levels are too high or if the levels are slightly higher than the normal limit. Okay, if the PSA levels are slightly higher than the normal limits, then what we are going to do is we are going to send some investigations like ultrasound. We are going to send, okay, to have a better idea. We can also take the biopsy by if the PSA levels are very much raised, to rule out the cancer. Okay.
Okay, what if my PSA is low, doctor? Does it mean I don't have any cancer?
It doesn't mean that you don't have any cancer, because as I mentioned, the PSA levels can fluctuate because of many reasons. Okay.
Okay.
So
What happens
for the
if I have prostate?
so for the what? I'm so sorry, I couldn't hear you.
Sorry, what happens if I have prostate cancer, if I'm diagnosed with prostate cancer?
What happens if you have a prostate cancer? Okay, that's a very valid concern you have. So initially, we will just see how it is going to progress. We will check how it is affecting your urination. Then we can go for some surgeries as well. Okay, then eventually we have some things known as radiotherapy. And the very latest thing which is coming these days is hormonal therapy. That's very useful. So we have a lot of things that can be done. But for now, I would suggest you to just get PSA done and don't think negative about your condition, okay?
I'll try to do that, doctor.
Yeah. Be strong about it. I will prescribe a PSA test and I will give you some advices. And that's a very good thing that you have come and you are taking care of yourself. So some advices which I'll give you is to practice safe urination. Like you should always maintain your hygiene. Okay.
Okay, doctor.
Okay.
Great.
Exercise daily.
Okay.
Take a good diet.
Okay.
Okay.
Doctor,
Okay.
I also heard that prostate cancer is also examined clinically. Is it right?
Yeah, we can have a physical examination as well. But for now, if you, I don't feel like it is needed because of the symptoms which you are telling me.
Okay.
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 Since you're here for a PSA test, so we will just get a PSA test done, and then we'll proceed accordingly.
Okay, doctor.
Okay.
Sure, doctor. What are chances that I may have prostate cancer?
To be honest, slight.
Yes.
The chances are very slight, but we'll have a better idea once we have the test results. Okay.
That'll be great, doctor. Yeah, that'll be fine.
Okay. So, do you have any other doubts?
Okay, no, doctor. I'm just worried about it. Hope my results comes out normal.
Yeah, we all hope for that. And if by any chance, once you go back home, if you feel like you're having blood in urine, okay, by any chance during night time the urination is increased, or maybe you're not able to control your urine, okay, or maybe you are experiencing any weight loss, do come to us, okay. And for the time being, the PSA test will be done, and it's a routine referral for the PSA test. And once we have the results, we'll let you know what it is, okay.
Sure, doctor. No problem.
Do you have any other doubts?
No, doctor.
Okay. Thank you and have a nice day.
Thank you, doctor.
Okay. Bye-bye.
Bye-bye. So, how long do you take?
It's 9 minutes.
9 minutes. Okay. Okay, guys. Actually, this case is more of addressing my concerns, because it is not like taking a station. More of addressing my concerns. I have come because
Exactly.
yeah. My
So
friends
in
have.
this case, I would suggest you guys to not to go for PMF, TOSA and all too much, because the patient in the PLAB 2 exam also will be speaking a lot. You just have to answer him. Okay. So Harish, any feedbacks for me? What could have improved?
So yeah, definitely, yeah. When I asked you about parectal examination,
Mm-hmm.
Not feedback to you actually. Why we don't perform correct examination is it actually varies PSA levels. We can give the reason to the patient if at all the patient need for the examination. That's the reason, one of the reason. In exams, if at all the patient comes for the PSA testing, never perform correct examination, because if you perform correct examination, then you send the patient for PSA, the levels will be high. So it's going to decide whether you're it's going to decide whether you're making a very blunder here. So never perform correct examination if you're ordering for PSA in some patients. Did you guys get it?
Yes. So
Yeah, cool. Yeah, pretty much that's it actually, not much. Guys, do you have any doubts in this? What are the discussion we went? Please ask us.
like this is the very common case which repeats after every 2 to 3 days.
True.
Just be very well prepared for this.
I have a question.
Yes, please.
Yeah. So if the patient is young and he still needs a PSA and the symptoms are all normal, can we proceed with letting him have that investigation, or should we deny?
Yeah, like the question is really good actually. Thing is, young patients who have no symptoms is just worried about thing. Usually we don't perform the PSA actually. Even I'm really not sure, but usually we don't perform because the patient is having doubt. But I'll let you know about that, because unless the patient is more than 55 years, we won't perform PSA for the for patient. Or what we can do is we can explain to them that this is normal, or if at all if some symptoms comes back, if at all he is having any symptoms, he can come back to us. But I'll definitely find out answer to this and give you
No,
correct
the answer to
Uh,
it is like if by any chance if the patient is like behind you to give, you have to convince for the whole. It's a 8 minutes thing. Okay, it's not the real life thing. So for the 8 minutes, you have to convince him that it is not needed in your case. It is not needed. You can go that way, because we don't want to use the NHS resources which are for waste, because we have to preserve the resources which NHS is providing us. For the 8 minutes, you have to convince that person. Till the time the person is convinced. If the person is not convinced, your station will be over by the end of the 8 minutes. Don't give it. Okay.
Okay.
No, thank you.
So how to prolong this case for 8 minutes? Because you just have to
It
say
can be
no.
prolonged easily.
Yeah, so what you can do is ask him his history. If you know this case, okay, this is the case, then you can start asking his history. So most of the time will be spent here. Then you can then again you can start solving his questions, like answering his questions, so that the time you can manage. Because after 1 to 3 minutes, sometimes you may not have anything to say to the patient. Like you don't have enough words to use and convince the patient. So what you can do is ask about his history and what are the reasons why you think so. You can explore it, explore. Then yeah, and at the same time you address his concern, that you can do.
Okay. Thank you so much.
Sorry, someone said something.
It's okay. Let's move ahead.
Okay. Okay, we'll move ahead. Now the OBG and gynecologist thing starts. Okay, now when the patient comes to you, the thing starts list taking. Okay, it's again the same thing. Okay, asking about the patient presenting complete. Here the questions will be different. So after you greet the patient and introduce yourself and confirm patient's details, and always keep smile. That's really going to improve your IPS. Always keep smiling. So if at all you know that patient has come for the antenatal visit, you can paraphrase you can paraphrase and say like this: understand that you have come for routine antenatal visit. How can I help you today? How are you doing? Like what is symptom? If you have anything. So when an antenatal patient and any pregnant lady comes to you, you have to rule out few things that are very crucial. I mean, okay, I'll tell you what are those things. You should always rule out preeclampsia. So ask about the questions about preeclampsia. Like, do you have any swellings in the legs? Do you have any headache? Do you have any pain in the abdomen? So ask these questions so that you can rule out. And after some time you can check check the blood pressure, but you can ask all these questions so that you'll have a better understanding. Then ask about present pregnancy, whether she's appreciating fetal movements, or she whether the fetal movements, and there's any medical problems like any discharge. You can ask these questions, and you can also ask whether any patient has any clots in the legs or lungs previously or presently, or she's on any medications for that. Because pregnant lady are more prone for these clots. So that's the reason we ask all these questions. Even the medications, we have to rule out whether the patient is taking any life-threatening, any teratogenic medications for the baby, which is teratogenic for the baby. So taking all this history, you go with the for the PrepMedico, but don't concentrate on this or medication plots on this, because there's a lot to ask in OBG cases. So next is ask about previous pregnancies. First, once you take the present pregnancy history about any regular antenatal visits, whether she visited midwife regularly. Usually, the case which comes to you are like maybe little complicated or maybe some irregularity, because usually midwives sees the patient first, and if at all there is any abnormality, they'll send to you. So in these cases, ask the patient what is the reason for their visit to you. Now ask about the patient's previous history. What are the previous? Ask about previous pregnancies, whether the patient has any previous pregnancies, and was it was there any miscarriages, and what was the reason? Miscarriages is considered like when there's abortion before 24 weeks is considered as a miscarriage. Ask about any previous miscarriages. Then I'd ask about any previous whether she was regular with her antenatal follow-ups in the previous pregnancies. Then you can also ask about smoking or drinking history. Ask about any previous sexual transmitted diseases, because these are the things which will affect the present pregnancy. Next is ask about family history. Anyone in the family has suffered from clots, lungs, or from the lungs or legs. So this will help you in ruling out, whether to consider antiphospholipid syndrome. Pregnant lady, when these are one of the main reasons for miscarriages in pregnant women. So you can ask all these questions. Then ask about anyone in the family has any previous had history of miscarriage. So you ask a menstrual history, whether you can start by asking, I need to ask you about your menstrual history. Then ask about her last LMP. Are her periods are regular? Are there in how many days they usually normally bleed? And ask about any previous experience in excessive pain. About menstrual history, you can ask these questions. Don't if at all it's very necessary, spend much time here, but otherwise move forward. And okay. When you ask about previous pregnancy, when you ask about when they have childs, you can ask whether how the childs, whether this was normal delivery or it was any C-section, and what was the reason, and whether the baby is good, is healthy, and is feeding well, any problems. So you should ask about, you should follow this. Whether present pregnancy, ask about birth, that is P-BANs. You can follow P-BANs. That is P is for pregnancy, ask for present and previous pregnancies. Then B is about the birth. How was the birth? Whether the baby has any, it's normal or it was C-section. Next comes the whether the patient has any immunization, is regular with his immunization. So I can ask this question, and whether the baby is growing well, any problems. You should ask about, follow this way. Present pregnancy, PrepMedico covering this, then you go with the previous pregnancies, how is the baby, then you go with the family history, then you can move on. So once you ask all the history, usually the cases which you get, you have to rule out some. It can be a preeclampsia, it can be a female who have come in the intention of having a male baby. So it depends on what case you're getting. Some lady can come with pregnantly come to you and they'll ask, I need to abort because because I think the child is female. So in these cases, that there'll be you should concentrate more on addressing their concern and explaining why is it is not good to abort, and why is it not We won't actually about based on the sex of the baby. You have to explain to them. So once you finish this, ask about her, how she's doing. Like ask about if she has any symptom. Ask about any idea. Follow the eyes. Ask about any idea what could be the reason for a symptom. Ask about a concern. And while following PMF also, asking PMF to ask about any medications, allergic to any medications, any travel history, and social history, sexual history. Ask about anything that she would like to tell. Because in some antenatal cases, there'll be some abuse. So you have to actually ask about her mood sometimes. Depending on the patient's symptoms, you should ask these questions and assess. So we need to rule out. So once we are done with this thing, we can go with general examination. So what is general examination we do in pregnant ladies? So we usually check for blood pressure mainly. So because preeclampsia, we are doing rule out preeclampsia in pregnant ladies, and heart rate, temperature, and oxygen saturation. We usually perform these. So once you're done with the general examination, you can go for abdominal examination. So as I told you, you first have to taking consent from the patient is very much important. So you ask the permission and tell her what is the reason that you would like to do this examination on the patient, what is necessary. Take patient permission, offer privacy of a chaperone, and ask the patient to expose adequately. So once you offer all these things, inform the patient what you're going to do and why is it necessary. So this will be the sentence. I just put a sentence or how we can explain to the patient. I'll be examining your pregnant abdomen. It involves looking, feeling, and feeling the baby's position, taking some measurements, and auscultating for baby's heartbeat. So if you tell this thing and explain why it's necessary to check the well-being of the baby and mother. So we are doing this to make sure the baby is well and is growing well. So once you explain this, they'll be very much happy and they'll be accepting. They'll be okay with the examination. So once the baby you offer take permission, privacy, offer chaperone, then you can go with the examination. So abdomen start with inspection. So check for the shape of the abdomen. Check for any fetal movements that you can see, and any surgical previous C-section scars, linear niagara. So, and you can also see any redness or any uh, swollen veins. So once you are done with inspection, go with the palpation. For palpation, you can check the temperature first. So like in abdominal examination, it's always use the back of your hand and compare with the thigh. Check for the upper border of the uterus, like if checking for the the upper border, then we can also, after checking for the you can palpate for the lateral borders. We are going to examine lateral borders just so that you'll know the lie, fetal lie actually, whether the patient cephalic position, whether whether the baby is in cephalic position. So once you and which side is, whether the back is in the right or towards the left. So we need to assess this so that we'll know the lie, fetal lay of the baby. Then after this, you have to assess the presenting part of the pelvic rib. So when you examine the pelvic rib, you'll get to know whether if at all it's round and it's palatable. Palatable. It means you can hold and you can. We'll actually help you with the examination in the future. Like we'll arrange some. Make a offline section or something so that you'll have a better understanding about the examination. So check for the palatability and see whether the presenting part is fetus, presenting part is his head or is it breech. So once you examine this, then you move for further. That is, you have to measure the height of the fundus. That is, measure from the symphysis to the fundal height using a tape. Measure in the inch, like inch there, where the measurements are in the inch, so that you are not biased. Because when you measure the from centimeter set, obviously you'll be biased. I mean, like you can just randomly say, sorry. Okay, you can use inch size so that you won't be biased telling the age of the gestation age of the baby. So once you're done measuring, then you can go with auscultation. So auscultation for what? You have to check for the baby's heart rate. So where you're going to place the fetoscope? You're going to place it between fetal shoulders and fetal back. So when examining the lateral borders, you'll come to know which is back and which is the head and which is the beach. So you'll be placing the fetoscope between the shoulders and fetal back to examine for the heart rate of the baby here. So yeah, by assessing this assessing fetal heart rate, you can consider whether the patient is in any whether he is having any ischemia or is in any distress. By measuring heart rate, you'll definitely know, and we can further go and perform CTG to make sure the baby is safe. So once you complete the examination, allow the patient to dress up. So explain and when the make the patient comfortable and start explaining findings to the patient. Explain about the inspection to the patient, whether abdomen is gravid, appropriate for dates, and what you observed, whether visible there's any visible linear diagram, and palpation. Abdomen, what do you feel? Because abdomen is soft, non-tender, the single fetus, longitude. This is just a example. I know it's not like really have to tell. Depending on what findings you get, you have to explain. Non-tender single fetus, whether it's longitudinal layer, whether it's transverse lie, whether it's cephalic presentation, a breech presentation, whether the head is engaged or it is not engaged. So depending on what patient, like what you find in examination, you can explain to the patient. So what are the routine investigations you do in antenatal case? That you have BC, urine test for infection, infection screen for syphilis, hepatitis, rubella, chlamydia. This usually cause defects in the baby. So that's the reason we have to rule out all these things. And then ultrasound scan of the abdomen. So once you perform this thing, you have to explain to the patient. This is the clinical findings I got after examination, but I need to confirm this by doing ultrasound scan. So it's always better to explain this to the patient. So counseling actually, pregnant lady usually they come with some symptoms like whether patient may have come with continuous miscarriages. So they would have scared about they will have miscarriage again. So what is recurrent miscarriages? Recurrent miscarriages, miscarriage that occurs for 24 weeks or more than 3 times. So when the miscarriage is more than 3 times, is considered recurrent miscarriages. So whenever the patient comes with 2 miscarriages, the success rate is same as normal pregnant woman. So explain this to the patient. Then I got preeclampsia. So what are the complaints patient comes with? The patient may have a headache, or patient may have pedal edema, and the blood pressure will be high. So what you have to do is assess, continuously monitor the baby heart rate, put on CTG, monitor, and if at all the blood pressure is still high, admit the patient and give her medication, labetalol. Usually they give labetalol, but depending on the hospital guidelines, they treat accordingly. If at all, during patient who comes to hospital, they'll have some concern, they'll have some questions that you need to address. I'll give you a few examples, what questions they usually ask. They'll ask whether they can have water birth. So usually water birth that's common, it is allowed. But what happens is whenever the patient has preeclampsia and delivering the baby, we need to monitor the baby continuously. So we have to explain to the mother, so we won't be able to. It's not good to have water birth because we need to monitor the fetal continuously. So if at all we are not doing that, there may be harm to the baby and mother as well. So we need to access and we need to explain to the patient why it is not good to have water birth or home delivery. If at all everything is fine, actually is there a lot of people do have this home delivery, but depending on patient condition, we have to change. So these are the counseling sessions. Then so whenever the other main thing is whenever patient says the concern, whenever the patient is worried about something, explore those symptoms, explore those actually, what's the reason, why are you feeling this way? And once they say validate, oh, I understand that you're worried about this. And is there anything that I can do? Validate it and show empathetic response and just say, okay, I'm really sorry that you're going through this. I can, or how can I help you? So this is this other thing that you have to do, to be a better doctor, be a good doctor. Next is management, advise pregnant women on their lifestyle, whether ask about whether they're doing regular exercise, proper diet, explore. Then either you can provide them pregnancy book, which contains antenatal care information, and explain about alcohol smoking is actually smoking should be avoided and alcohol should be in limit while the mother pregnant. Then you can also speak about place of birth, whether the mother can decide where they want the baby to be born, and about diet and folic acid and vitamin D supplements. You can actually provide this, or if the patient is already taking this well and good. And this is about time management. So as I told you, you can divide your time into 2+3+2. First 2 minutes you can take. So it's actually 3+2+3. Sorry for that. The first 3 minutes you can take history. Then the next 2 minutes you can speak about diagnosis. Then after that, the last 3 minutes you need to explain what is the diagnosis. They'll have some questions you need to address that. So after addressing, what are the management plans you can do? So always mention about but all safe. It's always better to give some safety net, like tell if at all the symptoms increases, if at all they're feeling if it is they're feeling the symptoms getting worse, you can always come back to the emergency and provide them leaflet, and you can provide them emergency support where they can go. So that's what a safe doctor can do. And always before entering exam, exam hall, you have to be always keep yourself calm. Make best use of 1.5 minutes that you get before you enter into the station. Practicing with different candidates. Try to practice with the different candidates so that it will give you a broad idea about what different languages. Sometimes it'd be difficult for you to understand what the patient is saying. So if you are able to if you practice it more, you have a better understanding of this. Okay, what I'm going to explain next is about during exams. Actually, you'll be tense. Most of the time, you'll be tense. So try to keep yourself calm. Meditate sometimes. Meditate. Keeping yourself calm really helps you in in speaking better. I mean, like, you can take good history and you can explain better. So whenever if you didn't perform any case or scenario well, don't worry about it. Come on, just shut your brain and you start. Okay, that's done. You can't do anything about it. Then start prepare for the new next case. So read the case. What is the case? Okay, what are the things I can ask in this patient? Okay, I can ask these questions. Okay, I can ask these are the main things I can ask in this case. So plan accordingly, then definitely you'll do better. Okay, guys, thank you so much. We have finished this. Now I would like to answer any questions. If you guys have, please feel free to ask me any questions. I will definitely try to answer your questions. Hello? Hello?
Hi, there was a word, grips under your history taking. Oh,
Yeah.
what was the?
Okay. Okay. I didn't mention you. Sorry for that. Okay. First thing is G is for the greet. So how are you going to greet the patient? G is for the greet. Tell hello. Wait for the reply, and they may say hi.
Okay.
Right.
Yeah.
Okay, R is for building the rapport.
Okay.
Okay, I is to introduce yourself. So once you tell a hello, it's nice to meet you, then you introduce yourself. Yeah, my name is so and so. I'm FY2 here. I'll be a doctor today. Can I know your name and your age? Then that's what you start speaking to them. Then next question is P. That is P is for the purpose. What is the purpose for the consultation? How can I help you today? What is the reason for a visit to the hospital? You can ask this question. What is the purpose?
Okay.
Next is S for smile. So always keep
Oh,
smiling.
Yeah.
It's difficult, but it should. Yeah,
Thank you. Thank you. Thank you.
no problem. Any other doubts, guys? You can always ask any other doubts like we just finish our PLAB, so you can like one more thing is about attachments. If you're getting any attachment before your PLAB, please take it because it's really going to help you. You can actually have a conversation with the patient, like you can really have the real conversation with the patient, so it's going to improve your the taking skills. And they'll in the hospital sometimes there'll be some programs, they'll teach you about how to speak to a colleague and how to manage angry patient. This will be really helpful for you for your PLAB also. So if at all getting an attachment before your exam, and if you have enough time to prepare for your exam, please take attachments. Any other doubts, guys? Hello? Guys, you can ask any doubts, and you can always provide us feedback. Your feedback is very much important to us because it'll help us to improve and do much better in the next sessions coming. And if you want any doubts, you can actually always put in the group so that we'll try to answer what are the doubts we have, and try to provide some feedback to us. Okay, I'll wait for some more time. If you guys have doubts, please ask me so that I'll be very much happy to answer your questions. Or anyone wants to do some case, please let me know. We'll do a case. Be volunteer, and I'll definitely help you.
Sorry, doctor, can I try?
Yeah, definitely. Can I know your name?
Yvonne.
Okay, Yvonne. Nice to meet you, Yvonne. Okay, I'll give you a case. Is that fine?
Yeah.
Okay, I'll give you a case now. 1 second. Okay. You are an FY2
Okay.
in maternity assessment unit. Just think
Okay.
OBGYN department.
Okay.
Okay, your patient is 30-year-old Alice Smith,
Okay.
who have come for the routine antenatal checkup.
Okay.
Okay. Okay. Other information you have about the patient is she's 36 weeks pregnant.
Okay.
Midwife already seen her.
Okay.
Okay, she's sent to you because her blood pressure is 160/110.
Okay.
Her urine dipstick shows protein positive.
Okay.
So this is your case. So take a focus history and discuss management with the patient.
Focus history and management.
Yeah, yeah.
Okay. Can I start?
Okay, one second. I'll keep the timing. Just in.
Okay.
Please start.
Okay, good evening. I'm Yvonne, one of the doctor over here. I will be assessing you and asking further question. Are you okay with it?
Hello, doctor. Yes, fine, doctor. Please.
Can I have your name, please?
Yeah, my name is Alisa. I'm 30-year-old.
Okay, great. Just to confirm again, you are coming for your antenatal checkup and you are currently 36 weeks pregnant.
Yes, doctor.
Okay, do you know that why you are being sent over to the hospital? To the midwife explain to you?
No, doctor. They just checked my blood pressure and sent to you.
Okay, actually, according to the record, you're actually having a higher blood pressures than the usual normal BP, and they actually found a protein in your urine for when they're doing a urine dipstick.
So I was having normal blood pressure, doctor. Why do you think it's high now?
Okay, so I have to ask you further questions to aid in my diagnosis. Are you okay with that?
Sure, doctor. Please.
Okay, is this your first pregnancy?
Yes, doctor. This is my first pregnancy.
Okay, have you had any issues before you have your before you are pregnant? Do you have any medical conditions like hypertension, diabetes mellitus?
No, doctor. Nothing as such.
Okay, so currently, do you experience any symptoms like headache, dizziness, or abdominal pain?
Sometimes I get headache, but not very much, doctor. I'm fine now.
Okay, so you didn't have any headache?
No, doctor.
Any tummy pain?
Sorry. No tummy pain, doctor.
Okay, any problem with your visions?
No problem with my vision, doctor.
Any frequent urination, like you need to go to the toilets very often?
No, doctor. Sometimes I have swellings in my lower limbs.
Okay, when did this swelling started?
It's been 1 week, doctor.
It's been 1 week. Okay. For your previous antenatal checkup, does the midwife mention to you have any other problem?
I was regular with my antenatal follow-up, and I never had any complaints, doctor.
Okay. So throughout your pregnancy up till now, are you feeling okay so far?
I'm feeling okay, doctor, but once in a while I get a headache, but I'm fine now.
Okay. How about your previous ultrasound scan and blood tests? Are they all normal?
Normal, doctor. No one told anything about it. They're normal.
Okay. I have to ask a bit about your family. Is there anyone in your family having hypertension? High blood pressure?
My dad is hypertensive, doctor.
Okay. How was his blood pressure? Is it well controlled?
He's well controlled now. He's fine.
Okay. I have to ask some sensitive questions. Do you smoke?
No, doctor. I don't smoke.
Anyone in the family staying with you actually smoke?
Not really, doctor.
Do you take any alcohol?
No, doctor. I don't take any alcohol these days.
Are you on any medications?
I'm not on any medications, doctor, but once in a while I may take paracetamol for the headache. Yeah.
Okay. So when is your last intake of paracetamol for the headache?
It was like 2 days back.
How was your headache? Is it really severe? How would
Yes,
you grade it?
I graded 6, doctor.
Okay. Does the paracetamol actually help with your headache?
Somewhat it's better, but not like it reduces to 4, but not totally.
Okay, so I would like to proceed with examinations and also relevant investigations. Any examination findings?
Okay, what examination you're going to do, doctor?
Okay, so to aid in my diagnosis, I need to examine your abdomen. Are you okay with it? I will have one strap around with me.
No problem, doctor. Your abdomen examination is normal.
Okay. Okay, so I would like to proceed with the ultrasound scan just to assess whether there's any fetal growth restriction and also whether the amniotic fluid is adequate. And for my currently, I'm suspecting preeclampsia.
Ultrasound is normal.
Okay, so I'm suspecting you're having a preeclampsia, which means high BP with some protein in your urine. since that you are having headache, I might need to admit you. Are you okay with that?
Doctor, why, doctor? I'm normal. I'm alright, doctor. Why I need to get admitted now?
Okay, so actually you are having a headache. I'm afraid that the PP might go on too high. So for further investigations, I might need to admit you and observe whether your conditions are stable, see whether the PP actually comes down or you need further medications.
Oh, doctor, what happens if I don't admit now?
There's a risk of a serious outcome, like you might develop like very high BP and end up with stroke. So I would advise that we get you admitted, start you on antihypertensive medications, and we observe whether the BP actually comes down. So once your PP is stable, I can actually discharge you home with some medications and arrange further follow-up in the clinic.
What are the complications, doctor?
So preeclampsia can be very severe. It can cause hemolysis, which means your blood cells started to lyse.
Okay.
And you can also have a liver problem. You start to have liver issues, liver injuries, and most seriously, it can end up with a stroke, and also intracranial bleeding. That means some bleeding in your brain. So the outcomes might not be so. The outcome might be serious, and we are trying our best to avoid that.
Okay, what treatment you're going to give me, doctor?
We'll start you on some antihypertensive. Do you have any medications allergies?
Okay, no, I'm not allergic to any medications.
Okay.
Okay, doctor. Doctor, okay, okay, I'm fine to get admitted here. But is it okay if I have a water birth in the future?
Depends on the control of the baby. You are already 36 weeks. We have to be very cautious with the outcome of the baby. So for now, I wouldn't have a definite answer, but we will see what is the conditions after further management. If the conditions allows, we might be able to enable you to go for water birth. But in case your BP is not well controlled, I think it's better that we try to have a birth in the hospital, which is more safe for the baby and also for the mother itself.
Okay, doctor. Is it okay if I take medication and go home? Because anyway, you've given me medication so that it will be fine.
I think for now, we have to admit you to monitor to see whether the medication is actually properly working and see whether it's effective to bring down the PP. So it's better we observe you for some period of time before we send you home. Are you okay with that?
Fine, doctor. Then I'll get admitted. No problem with that.
Okay, thank you so much.
Thank you, doctor. Okay, done?
Yeah.
Yeah, very good.
Very good, very good.
You really did well, actually.
Okay.
Yeah. I just have only two things to tell. That's it. But you are really doing good. Only thing is when you tell about the diagnosis, you have to give some space so that I can take it and I have to take the diagnosis, right?
Okay.
You explained good, actually told, but give a small pause there so that yeah. Then pre-eclampsia patients are more prone to have eclampsia.
Oh,
If the
okay.
blood pressure is not controlled, so you have to tell there's a chance that you will get eclampsia. It's seizures. So and if at all it is seizures, there'll be hypoxia to the baby, and the baby baby is in danger, and it may affect you also. So if you explain these things to the patient, there's more chance they'll be convinced. And usually, if at all the blood pressure is more than 160 by 110, usually we give a prophylactic, magnesium sulfate just to prevent eclampsia.
Okay.
Did you get it?
Yes.
Yeah. You asked good questions. Actually, most of the questions you covered in this thing. You asked about my pregnancy. Which pregnancy is this? Any family history you asked. And did you ask about? You should ask about travel history sometimes.
Okay.
It can lead to clots in the legs, and they're more prone. Also, pregnant ladies are more prone to it.
Oh, okay. I forgot about that.
No, you really did good. Okay, Nishita, is there anything that you would like to contribute?
No, I really like it. But
Yeah,
next time, keep your
Yeah,
camera on. We want to see your expressions also.
Okay. Doctor, just to double check with you, am I supposed to tell what kind of medications I'm going to give, or like general term like antihypertensive will do?
Okay.
Yes, you have to tell, because the thing is, other people in your batch will be knowing the medicine, and if you will not be knowing it, it may affect your marks.
So if I'm telling that labetalol or hydralazine, would that be fine? Or I need to
Yes.
go specific with the dose?
No, you're right. You're right. It's labetalol. Say it, because I didn't say it in my mock exam and I failed that station. So say labetalol.
Okay.
Okay.
You can say,
Okay.
yeah, you can say that. And you can mention magnesium sulfate also, because it's usually given for all the blood pressure is more to
Yeah.
prevent an eclampsia thing.
Okay.
Yeah.
Thank you
then-
so much, doctors.
And no problem. You did well. Good. Okay, anyone have any other doubts? I'd like to practice one more. Please let me know. Guys?
Or if by any chance, if you want to practice afterwards, just message in the group, and
Yeah,
one of us, whoever is available, will be there to make you practice. Okay.
definitely.
Any doubts? Okay, so we will end the session. So the next session, me and Manikandan are going to take. So it's on the topic. What's the topic, Harish? You remember the topic?